Hello, this is Dr. Nabih Mukhtar, Senior Clinical Fellow Critical Care Medicine UK, and in this video we are going to talk about the practical points in the management of ARDS, acute respiratory distress syndrome. So we will try to focus on the main practical points in the management, including the mechanical ventilation, fluid management, muscle relaxants, and proning. And the first point we are going to talk about will be related to the mechanical ventilation in acute respiratory distress syndrome. And what you need to know is that the main target of the mechanical ventilation is to achieve adequate gas exchange, but you need as well to avoid the mechanical ventilation induced lung injury. And there are two main reasons for the mechanical ventilation induced lung injury. The first will be the hyperinflation, which can occur if the patient took a high tidal volume and subsequently that led to increased plateau pressure, especially if more than 30 centimeter water. And the second reason will be related to the alveolar collapse, which could happen during expiration. So, to be able to avoid the mechanical ventilation induced lung injury, you need to avoid these two main factors, the hyperinflation and the alveolar collapse. So, how to avoid the hyperinflation? To avoid the hyperinflation, you need to follow what is called the protective lung ventilation strategy, which ensures that you maintain the tidal volume at low level, less than 6 ml per kilogram, with close monitoring to the end inspiratory plateau pressure, not to be increased more than 30 centimeter water. But you need to know that when you restrict the patient to a low tidal volume, that might induce respiratory acidosis with retention of carbon dioxide, which will be actually accepted as long as the pH is still more than 7.20, and that's called the permissive hypercapnia. And then, how to avoid the alveolar collapse? To avoid the alveolar collapse, you need to apply a higher PEEP, and in most cases it will be more than 12 centimeter water. So by this way, if you can keep and maintain these parameters, tidal volume less than 6 ml per kilogram and an inspiratory plateau pressure less than 30 centimeter water with high PEEP, you can maintain what's called the driving pressure, which is equal to the difference between the plateau pressure and the PEEP, to less than 14 centimeter water. And the evidence is saying that to keep the driving pressure less than 14 centimeter water is associated with a good management outcome of the acute respiratory. One of the other things you need to know, what are the targets you need to achieve to say that this patient is having an adequate gas exchange on mechanical ventilation. So the common practice saying that PO2 more than 60 millimeter mercurial and saturation more than 90% is actually a realistic target for acute respiratory distress syndrome patient on mechanical ventilation you need to achieve. So what are the other options you can do if the patient hasn't achieved the targets which we just mentioned? One of the other options is to increase the level of sedation, and this should improve oxygenation by two ways. The first is that it will improve the patient tolerance to positive pressure ventilation, and the second that it will allow resting of the respiratory muscles and subsequently reduce the oxygen consumption by these muscles, and this will end up of improving oxygenation. But you need to know that even with deep sedation, still the patient does respiratory effort and still there a diaphragmatic activity. That's why you might need to add on neuromuscular blocking agent, such as atracurium infusion, which will improve oxygenation. So, if you have an ARDS patient already on mechanical ventilation, well sedated, well paralyzed, but still not achieved the targets which we mentioned before, what other options you can think about? One of the most important other options you can think about is to put the patient in a prone position. Because there is a strong evidence that putting a patient in a prone position will improve the patient outcome and reduce the mortality. And theoretically, the PO2 to FiO2 ratio threshold to put the patient in a prone position is between 100 to 150 millimeter mercurial. But you need to think about putting the patient in a prone position as early as possible. And the sessions should be around 16 consecutive hours. Let's talk about some practical points regarding putting the patient in a prone position. First of all, you need to know that the prone position is contraindicated if the patient is hemodynamically unstable or having recurrent dysrhythmia or increased intracranial pressure. The second thing is that the ECG monitoring electrodes will be transferred to the back of the patient. And what about the NG feeding, the nasogastric feeding? If it is continuous infusion, it should be stopped at the time of performing the maneuver and restart on a low rate, such as 20 ml per hour once you're done. Then you can titrate up every 4 hours. You need to know that the patient will be kept proned around 16 hours and then deproned. And once deproned, the patient should be kept supine from 6 to 8 hours. The head of the bed should be tilted upwards by 25 degrees, and the head of the patient and upper limbs should be repositioned every 2 to 4 hours and maintain the normal alignment of the joints. So what about the role of steroids and anti-inflammatory agents in the acute respiratory distress syndrome? Basically there is no larger randomized controlled trial on the use of anti-inflammatory agents in acute respiratory distress syndrome has been shown to improve the patient outcomes. But it may be that steroids are more efficient at reversing the inflammatory process in the early acute respiratory distress syndrome, but are ineffective once a fibrosis is established. And indeed, fibrosis can be observed at day 7 of acute respiratory distress syndrome. The next point we need to talk about regarding the management of acute respiratory distress syndrome is the fluid balance management. And you need to know that the patient might need fluid resuscitation in the early management of severe septic shock which accompanies the acute respiratory distress syndrome. But when the patient is more hemodynamically stable, you need to follow what is called the conservative fluid management strategy, which will improve both lung function and shorten the duration of mechanical ventilation. Let's talk more about practical points regarding conservative fluid management strategy. First of all, you need to know that the general aim fluid balance will be from negative to neutral as long as the noradrenaline requirement is not increasing. Other points include that the patient should have general fluid restriction and the enteral feeding should be concentrated. The IV medication should always be in a minimum fluid volume, and you should use the enteral medications when possible. Also, you need to know that the furosemide can be used to drive the negative balance as a common practice. Thank you, and hope you enjoyed this video, and meet you in the next one.